A patient presents with what appears to be an infected diabetic foot ulcer. The surgeon debrides it. 3 days later, it's larger. Another debridement is scheduled and performed. It gets worse. Antibiotics are escalated. The wound doubles size. Everyone thinks the infection is winning, but what if there was never an infection to begin with? Pathergy is one of the most misunderstood phenomenons in wound care because it challenges the instinct that most of us clinicians are trained to trust. If the wound is bad, treat harder. But path- pathergy, I said pathology, pathergy, okay, flips that idea completely around. And in certain biological states, more intervention does not mean more healing. It means more inflammation, more breakdown, and sometimes more ulceration. In diabetic foot care and ulceration, that pathogy is quite rare. But when it does appear or overlaps with an inflammatory disease, it can completely change your management strategy. So, what exactly is pathergy? So, pathergy is an exaggerated inflammatory skin response to minor trauma, resulting in lesions that are disproportionately larger, persistent, and destructive compared to the initiating trauma. And this is not normal inflammation. This is not infection alone. It is the immune response and the immune system over amplification triggered by an injury. So, where does this phenomenon of pathergy come from? So, the phenomenon was first recognized through systemic inflammatory disease research, especially in conditions that were had where they had trivial trauma but produced significant lesions. It became classically associated with Behçet's disease studies, dermatological immunology in the 20th century, and early diagnostic skin testing experience. And, a key historical figure is Holusii Behçet, who discovered Behçet's disease and where pathergy, because I want to say pathology so bad, but it's the pathology of pathergy. Okay, but pathergy, where pathergy becomes a hallmark diagnostic feature of Behçet's disease. So, clinicians noticed something unusual to people when it came to Behçet's disease. A sterile needle prick could create a pustule or an ulcer, and that observation changed how the immune mediated skin disease was understood. So, what is Behçet's disease? Behçet's disease is a chronic inflammatory disorder involving abnormal immune activation and blood vessel inflammation. Ugh, forgive me. And common features include recurrent painful oral ulcers, like in your mouth, genital ulcers, eye inflammation, skin lesions, arthritis, vascular disease, and neurological involvement. And one of the hallmarks of Behçet's disease is pathergy. So, what is pathergy at a cellular level? So, pathergy is best understood as a dysregulated innate immune cascade. Usually it starts with very minor trauma. So the trigger usually is minor trauma. So this could be a needle puncture, a surgical incision, a friction injury, debridement, even adhesive removal in severe cases. And normally this will trigger a controlled healing cascade, right? But pathergy prone states, it triggers an escalation. So, also in pathogen, there is a neutrophil overreaction. So, the neutrophils flood the site excessively, and there is a high level of neutrophil chemotaxis, as well as excessive degranulation, as well as reactive oxygen species release. And instead of a controlled cleanup, the tissue damage increases beyond the original injury. Another thing that happens in pathergy is a cytokine amplification loop that's going on. So the key mediators become overexpressed. So our amazing mediators of IL-1, IL-6, 8, and TNF alpha, right? Tumor necrosis factor alpha. These create a feedback loop. And the feedback loop is inflammation, which causes more recruitment of immune cells, which causes more tissue injury, which causes more inflammation. So that's the feedback loop that happens in pathergy. Another thing that happens is endothelial dysfunction. So the blood vessels become what we say hyperreactive. So there is an increased permeability, there is plasma leakage, there is local edema, and there is a microcirculatory disruption. And this worsens oxygen delivery at the exact moment healing is needed. Another thing that happens is failure of the shutdown signals, and that seems like that happens also, like, with certain ulcers, right? We have too much inflammation. So a normal wound healing requires anti-inflammatory balance, so the IL-10, the T regulatory cells suppression, as well as a resolution of mediators. But in pathergy, the stop signals fail, so the inflammation persists and it expands. So this is diabetic foot files, of course. So can pathogy occur in diabetic foot disease? It's quite rare, and I've never heard of it with just diabetes alone. The important nuance is true pathogy is very uncommon in diabetes alone. However, pathogy like behavior can appear in diabetic wounds that sit on top of a severe chronic inflammation, infection heavy environments, vascular compromise, repeated mechanical trauma, and immune dysregulation. But in diabetic foot care alone, what is often seen is not classic pathergy, it's a hyperinflammatory wound escalation after intervention. So, wound care specialists often encounter what resembles a hyperinflammatory wound escalation. So, this is completely different from true pathergy. So, the patient may have pyoderma granulosum, vasculitis, autoimmune disease, and neurophilic dermatosis. And the wound is debrided because it appears infected. But instead of improving, right? Because anybody in wound care knows with regular diabetic foot ulcer, once you remove all the blocks, especially the blocks like the necrotic tissue, whatever, that wound closes up quickly. But instead of improving, right, the ulcer doubles in size, the pain increases dramatically, the violaceous borders develop, and tissue rapidly breaks down. And the clinician assumes more infection, but the actual problem is more inflammation. So this is one of the reasons why some patients undergo repeated debridement that make the wound progressively worse. You got to think of pathogy sometimes, but it's very, 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 very rare in just diabetic foot disease alone, okay, and diabetic foot ulcer. If they have like an underlying autoimmune disease, things like that, like I mentioned earlier, most likely like pyoderm granulosum is very classic with pathogy, right? We say chest disease. Okay, but because diabetic foot care frequently involves debridement, dressing, probing, surgical revisions, offloading adjustments, and repeated mechanical manipulation, if a patient has an exaggerated inflammatory response, then the treatment itself becomes a driver to the tissue injury. So, how do we know what is happening? How do you know if this is actually pathogy that's happening? So red flags are severe pain out of proportion. So the patient reports every time someone touches the wound, it gets worse. Honestly, when I first think that, I think PAD too, as well as a raging infection, right? And pain may be far worse than expected. A rapid enlargement after debridement, that is very key. So the wound enlarges within days after intervention. There are violaceous borders, so there are these purple undermined borders that are classic to pathergy. Cultures are negative, so repeated cultures fail to explain the deterioration of the wound. Antibiotics failed. They had multiple antibiotic courses that produced little improvement. And then there are going to be these stellate lesions. So new wounds appear around the trauma site. Is there a histopathology test for pathergy? No. There is no biopsy finding that definitively says this is pathergy. Pathergy is actually primarily a clinical diagnosis. However, biopsy may support the diagnosis by showing dense neutrophilic infiltrates, leukocytoclastic vasculitis at times, sterile inflammation, and absence of obvious infection. And pathology often helps exclude now squamous cell carcinoma, vasculitis, defungal infection, or atypical mycobacterial infection. And the biopsy supports the diagnosis, but does not prove that that is pathergy. So, what is the test for pathergy? In Behçet's disease, the test for pathergy is they use a sterile needle prick that is performed, and after 24 to 48 hours, they consider it a positive pathogen test if there is a papule or pustule or excessive inflammation that results from that. A negative is minimal reaction. The test is less sensitive today than historically, but it still is used in some centers. So, what are some wounds that are what we call pathergy prone or pathergy like? So, classic one is pyoderma granulosa. That is very classic. Is classic sterile neutrophilic, forgive me, dermatosis causes a rapid ulcer expansion after trauma. Vasculitic ulcers, immune vessel destruction, high inflammatory baseline. Severe infected chronic ulcers, so especially if they are polymicrobial or MRSA-like heavy wounds, there is a persistent neutrophil activation that is undergoing in that wound. Venustasis ulcers, because they have this chronic cytokine-rich environment and they're quite fragile, and they have a fragile healing balance that's going on. And there is a subset, when it comes to some diabetic ulcers, but usually it's caused by uncontrolled infection, severe edema and inflammation, or repeated trauma from the debridement. Okay, but debridement is actually quite key in a diabetic foot ulcer healing. Okay, because but you have to be able to tell the difference between certain ulcers, okay? And that's the key factor, all doctors know about pyoderma granulosum. We all know about that. So, pathogen testing, clinical tool, I already explained that. Now, are there labs that can confirm pathogen, right? Lab findings. They're more supportive than diagnostic. However, inflammatory patterns may include elevated CRP. That's to be expected because it is overreaction of inflammation, right? Elevated ESR, neutrophil predominance. Sometimes there are going to be elevated cytokine profiles, right? And an important point is that the labs will just pretty much show inflammation. They cannot show pathogen. Now, are there imaging that can confirm pathogy? Only indirectly, and it can confirm it. It would just indirectly support it, the possible diagnosis of pathogy. So MRI would show a disproportionate soft tissue edema, inflammation beyond the expected margins, no clear abscess matching to the severity of the wound. Ultrasound will show diffuse hyperemia and tissue fluid accumulation. X-ray usually is normal unless there's a secondary infection or osteomyelitis that is developing. And like I said, what would the pathology show? Like the tissue under a histopathology, it will show dense neutrophilic infiltrates, dermal edema, vascular inflammation, and tissue necrosis without proportional infection. Okay. So pathogens should be suspected when there is minimal trauma that leads to a maximal lesion. So examples, like I said, a needle puncture that will result in an ulcer, a debridement that will result in wound expansion, a dressing removal that causes more skin breakdown, a minor friction that causes these necrotic plaques. The key idea of pathogy is that it is a disproportionate response. And, when should you suspect it? I gave examples just now. If it gets worse, pain out of proportion, debridement accelerates the breakdown, infection workup is negative, and if the patient also has an autoimmune disease, such as having a history of Behçet's disease, inflammatory bowel disease, or rheumatoid arthritis, lupus, or vasculitis. And has pathogy ever been diagnosed or reported in diabetic foot ulcers? And like I said, the most common reported scenario is not diabetes because pathogy. It's because a patient who has diabetes develops something like Behçet's disease or pyoderma granulosum or neutrophilic dermatosis. The lesion is mistaken for a diabetic foot infection, necrotizing infection or osteomyelitis, and aggressive debridement follows, and the ulcer continuously rapidly enlarges. And eventually, a dermatological evaluation reveals that it's an inflammatory condition rather than primary infection. But these cases are very uncommon, but well described in wound care literature because they often lead to delay in the diagnosis and sometimes unnecessary amputations, unfortunately. So why is this a deal? What's the big deal, right? For me to mention it. Because, pathogy is essentially a loss of immune regulation after injury. And instead of the controlled healing cascade that we want, the inflammation is amplified, the resolution signals fail, and the tissue damage becomes self-propagating. And it behaves like wound healing more. It behaves less like wound healing, right? And more like that negative feedback loop that never shuts off. So, what are the treatments for pathogy? Managing pathogy is not about more aggressive wound care. It's about calibrated restraint plus immune control. So one of the most important steps is reduce mechanical trauma. So avoid unnecessary debridement, minimize repeated probing, limit tissue manipulation, use atraumatic dressings. We did an episode on that. Next is control the inflammation. So depending on the severity, some clinicians will use topical corticosteroids, which will control the localized inflammation. Systemic corticosteroids, they usually use that for moderate to severe cases. Immunomodulators in a refractory disease, this is essential, especially important if there is suspected neutrophilic dermatosis overlapping. So you actually have to treat the underlying drivers of this as well. So if there is a systemic inflammatory disease present, that has to be treated. If there's vasculitis, if there is severe infection, but that has to be confirmed, and metabolic instability. So, if the patient has diabetes, but they end up developing something like Behçet's disease or like we mentioned, a pyoderma granulosum, yeah, the diabetes still has to be managed and controlled. So you have to definitely be very careful of the infection differentiation of pathogy. So one of the hardest clinical challenges is pathogy can look like infection, but it's not always infection. So clinicians must avoid over debridement if it's not infection, right? Or over surgical escalation without confirmation or blind antibiotic escalation without evidence. So instead of us saying debride aggressively until clean, if the patient has pathogy, we have to shift to saying stabilize the inflammation, protect the tissue, and intervene only when is clearly necessary. Okay. And so, what is a major clinical risk for our patients who have diabetic foot care? So, the danger is the misinterpretation, thinking worsening equals infection and responding with more debridement, which will cause further inflammatory escalation if it actually is pathogy instead of an actual diabetic ulcer. And like I said, it will continue with that feedback loop of intervention equals inflammation equals perceived worsening, where it is causing more intervention. Okay. So, pathergy teaches us one of the most important paradoxes in wound care, that sometimes the wound worsens not because you're doing too little, it's because the tissue cannot tolerate what's being done to it. And in our diabetic foot management, we do see pyoderma granulosum sometimes. We do see patients who have Behçet's disease. And it's a skill to know not when to intervene, okay? Like what not to do and what to do. That's why I keep on telling people it's not a one size fit all thing in wound care. It is quite tricky. That's why you need to know what's going on. You can't just look at it and say, "Aha, I know what that is." Okay? It's definitely like an episode of detective or true crime. Like literally, we have to figure out exactly what's going on. So the most infected wounds improve if a wound is actually infected and it's not an autoimmune disease where it has pathogy. Most infected wounds do improve with debridement. But pathogy teaches us that some wounds, because they get debrided, they worsen. And that's a challenge which, the wound is telling you to put down the scalpel, okay? But that is when it's diagnosed pathogy, okay? That is not when it's a nice, clear, classic diabetic foot ulcer. So you have to know what not. And that's the whole point of knowing all these different types of wounds. Because limb salvage is not just technical, it's biological, it's timing, it's immune awareness, it's called controlled restraint. And it's quite fascinating, the world of wound care. And so this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.